Good morning. I'm Dr. Joe Wiersbecki, and we are on the forum. I've been a regular guest with Pat for several years now, and today I'm the guest host. I'm coming to you live from the studio, and calling in will be my partner, Dr. Paul Johnson. And again, my name is Dr. Joe Wiersbecki, and I'm a local orthopedist with Florida Orthopedic Specialists. And we have two offices in the area. One office in Port St. Lucie on the corner of Highway 1 and Walton Road. And then the other office is in Stuart, near the intersection of Indian Street and Highway 1. You may know a lot of my partners like Dr. Powers, Dr. Forrester. Dr. Johnson, of course, is going to be joining us. And if you want to get a hold of us and come and see us in the office, our telephone number is 335-4770. Again, that number to see us in the office is 335-4770. Or you can find us on the internet. My website is drw.org. Doctor all spelled out, w.org, or of course, search Florida Orthopedic Specialists, and you'll see our main webpage also. And I think I heard Dr. Johnson is here. Dr. Johnson, you with us? Oh, great.
Good morning.
Morning. How you doing?
I'm doing well. How about yourself?
Very good. Thank you. I was just giving a short introduction to the audience. The show that we're doing is called The Forum, different than our normal show on Bone Talk on the other station, but same format, just you and I talking about orthopedics and general medicine.
Sounds great.
Great. So, Dr. Johnson, remind me, I always tell people that you're Navy trained because that's what always the patients come back telling me about. They love your Navy training and your technical skill and whatnot. Can you remind everyone about your background, your training and whatnot?
Oh, sure. So I spent a lot of time in school. I was, scared to get into the real world for a while. So I did undergrad at Tulane. I did some graduate work at Columbia University, and then went back for med school at Mount Sinai in New York. Completed a residency in orthopedic surgery at Albany Medical Center in New York, a level 1 trauma center. And then I went and did 4 years of sort of general orthopedics with the Navy. So I got a chance to do a lot of everything orthopedics wherever the Navy needed me. So I was in Japan for a few years and out on the West Coast. Went back and did a fellowship to kind of hone my skills a bit further, and that was in foot and ankle. And then I've kind of settled now into that sort of lower extremity niche. So hips, knees, ankles, feet, doing joint replacements, sports, trauma, all that sort of thing.
Yeah, so you're doing everything from trauma surgery, of course, a lot of your training. So someone breaks their wrist or breaks their hip or needs a hip replacement and needs an ankle surgery. Give me the list of surgeries actually that you do.
Sure. I think you hit a lot of them there. So I think the big ones are going to be things like total hips and total knees. We do a lot of sort of fracture work. So your ankle fractures, wrist fractures, hip fractures, those sorts of things. Let's see. We also do a lot of reconstructive work, especially in the lower extremities. So for things like the knee, if there's an injured meniscus, a torn ACL, can certainly do those. For the ankle, sometimes we're looking at some ligamentous injuries, so a bad sprain that doesn't heal well. We can reconstruct those ligaments. Tendons that have gone on to either wear out or are sort of torn or even ruptured, we can fix or sometimes even replace those. Sort of more chronic conditions as well for the arthritis or for, let's say, a collapsed arch. Things that we can do to either rebuild or reconstruct or stabilize those issues too. So fusions and tendon transfers, a lot of different things that we can do to kind of rebuild and restructure a lower extremity that's had acute trauma or just sort of repetitive wear and tear over the years.
Okay. Well, great. And so basically the limits of the surgeries that you wouldn't do, so you basically do everything but spine surgery and like shoulder replacements in the orthopedic realm?
Yeah, I think those are probably the big ones. A little bit more involved, and certainly with some specialists who have kind of made that their area of focus. I think those are areas where people are certainly better suited to have that specialist to address those conditions.
Oh, great. Yeah, and of course, we do a lot of non-surgical work too. What is it, like 90% of orthopedics is non-surgical, and that's my specialty. Again, I'm Dr. Joe Wiersbecki, and so I'm the specialist with the non-surgical things, but of course, in your practice too, I'm sure the large majority of your work also is the non-surgical standpoint.
It's absolutely right, and I think it is probably about right. Those numbers that you're putting out there, we sort of try the non-operative route, and for a lot of folks, that either gets them where they need to be, or can certainly, in the case of let's say a joint replacement, buy a lot of time There's no need to rush to a surgical fix if there's a good non-operative treatment. And I think, as you say, the vast majority of people will do very well with some of those more basic things, starting with the least invasive and working your way up to, and maybe not even getting to the surgical side.
Yeah, hopefully not. And I'm always telling people we want to start with things that work, that are that are lower risk, and then if things that should work are not working, then we have to kind of move our way up that hierarchy, that ladder, to try things that are a little bit more high risk. And of course, the highest risk out there things would be the high risk medications like the narcotics or some surgeries, depending on your risk factors and that surgery that you'd be talking about for that problem.
I think that's right. I love that idea of the ladder. You don't jump up to the top rung. You work your way up one step at a time, and if you get where you need to be, you stop there. And I think much like a ladder, the higher up you are, the greater the risk potential. Hopefully nothing bad happens, but certainly if you can get someone happy and functional and doing well with the least amount of risk, with the and I guess the flip side, the best benefit, 100%, that's the right way to go. But there are occasions where people don't respond, or are doing well for a while, and then things kind of start to deteriorate a little bit, then you move on to that next level. But I think it's always one step at a time. You want to do right by these folks.
Absolutely. And Dr. Johnson, I know you're a research nut just like I am. And so I figured I'd maybe pick your brain with some of the more common questions that I get in clinic and see where that takes us. So,
Sure.
So let me ask you here, when patients ask you about things like the CBD oil or the topical medicines or like glucosamine chondroitin pills, how do you break those down? Some of those alternative treatments that could potentially help with their pain that they hear about from their neighbor or whatever.
Sure, and I think it's a tricky issue because it is out there, and I think part of it is with a little bit less either knowledge of the research or some of these newer ones where the research isn't as robust. It's tough. It's a lot of word of mouth, and so gauging how well these things work is a little bit iffy. And especially when you have other medications that are well documented, well researched. I'm thinking sort of ibuprofen is the big one most recently, where there's a lot of sort of bad press that comes out. And someone who's looking through their medicine cabinet says, "Geez, I've been taking this. Am I at risk? Is something bad's going to happen to me?" They start looking at those alternatives, which seem maybe a little bit lower risk. I think in terms of lower risk, that's probably right. And things like CBD or chondroitin sulfate don't have haven't been documented to have a very high risk profile, meaning that the risk of a side effect or an adverse reaction are pretty low. On the other hand, I think the data also aren't so great at sort of determining that there's a huge benefit to those medications. And so they're not harmful. And there is a certain percentage of the population who will probably get some kind of benefit, will feel better for having taken or used them. But it's really tough to tell you that there's a high likelihood that they're going to help you out. CBD is maybe a little bit more of a question mark there. There's some early data that suggests it has some anti-inflammatory properties. But my understanding is they haven't really mapped out an appropriate dosing regimen as yet. The research isn't there. And so there's certainly some promise, but I think finding out the right concentrations and frequencies of dosing and making sure that the products are more uniform across the board. I think if you get two different CBD products, you're probably looking at almost completely different animals at times, because the amount of the medication is different, how readily it's absorbed may be different. And so standardizing those things would make it a lot easier to kind of measure the response that people will get, how well it's going to work for them. Chondroitin sulfate has been pretty well looked at, and I think in general the data show it's probably a little bit better than placebo, but not much. And I think the one risk that I'm aware of is that some of those are formulated with a lot of salt, and so there's at least the potential for folks who are sensitive to that, high blood pressure and so forth, who have maybe been advised to avoid a lot of sodium intake or salt intake. They should just, with some caution, maybe treat those with a grain of salt, I guess, in terms of how well it's going to work for them, and maybe the risk is not worth taking that the chance of a benefit.
That's interesting. I didn't know too much about that salt component. Do you know? Are we talking about a large amount, or is it really only someone who's really more at risk to an increase in their salt, like the people with CHF, volume overload, and they're really on a tightly controlled thing that if they started this out of nowhere, that they're at risk? Do you know what kind of salt risk we're talking about here?
I think it's relatively low, and so I think you're right. I think it's more that second group, people who have been specifically advised to take caution with their salt intake. So when they start using that, should just sort of monitor for those things. And I don't think it's necessarily a dose or two that's going to tip them over, but if they've been cautioned by their physician for those other medical conditions, saying, listen, you got to watch your salt, as opposed to that sort of general, the general doctor's advice, eat healthy, get lots of exercise, vegetables, watch your salt, that kind of stuff, I think it's probably safer. Whereas someone who is very specific, like you say, with fluid overload risk, or someone who is already having issues controlling their hypertension and have maybe been told to watch the salt intake because that increased fluid can certainly set off the blood pressure risk. I think those are the folks that I have, my understanding is that should just use that with caution and certainly make sure they're letting their doctor know, hey, listen, I'm going to try this. What monitoring do I need, and sort of mapping out that initial schedule. Sort of like you would with any sort of major change in your dietary intake or new medications. You want to make sure that what you're doing new will not interfere with the current status of things.
So your standard person with high blood pressure then is probably fine to start this.
I think so.
Just monitoring your blood pressure on your own at home
Exactly
type
right.
thing. Make sure there's no change.
Exactly. You've got that cuff at home or something, or someone who can help you do it, and just sort of take a uniform reading. And I would do that probably about the same time every day in a uniform environment. Blood pressure very sensitive to activity and sort of when you're taking it. If you get off a bad phone call, probably not the best time to check your blood pressure. But and so if those measurements start to creep up consistently, I think that's a little bit of a warning sign. And if that's sort of the new and different thing, starting some of these medications or supplements, it's probably worth at least making sure and maybe stopping it for a little bit, checking to see if it responds and comes down. Or if those numbers are really coming up, then of course seeking the right medical advice from your physician to make sure that you're taking the right steps.
Yeah. Oh, and for years I'd been telling people that anti-inflammatories really shouldn't be changing their blood pressure much. And I actually just came across the study again that looked at that. And depending on the anti-inflammatory that you're talking about, ibuprofen versus Aleve versus Celebrex, that change in the blood pressure on average is just a point or two. So from taking you from 120 over 80 to 122 over 82. So we're really not talking about much change in the large majority of people, but that's an average. So that's just something I thought I'd throw in there that I finally came across that study again.
I agree. It's a great point, and I think that's kind of the danger of there's a lot of mistranslation. I think is probably at the heart of it. So these studies come out that are maybe a little bit more nuanced, and then, let's say the major media who wants to report, the latest scientific findings kind of interprets it as best they can and make maybe overgeneralizations. And so, like you say, a point or two increase will increase your blood pressure. And that's not the layperson's understanding of it. So it's good to keep in mind too that these medications do have some significant benefits for a lot of people. And it wouldn't be a step I would necessarily leapfrog right over to something that might actually have a legitimately increased risk of a significant adverse effect, something bad happening. Just because there's that theoretical risk. I think with the right monitoring and the right patient and a good history and a good discussion with folks, you can certainly use these medications with a high degree of safety for the vast majority of people at any rate.
Yeah, I agree. And about some of those general questions, I'll kind of chime in for just a second here. That I asked you about the glucosamine chondroitin. I completely agree with you. Yep, what the data shows is that it's a little bit better than placebo. Some people swear by it, and for those people who swear by it and says that it works for them, hey, great. I can't argue with success, so keep up with that. But I tell the majority of people who are asking about it, to start for their miserable pain in their knee or whatever, that I really wouldn't put all their eggs in that basket, that's likely not going to move the needle that much for them. And the same thing kind of goes for the CBD oil or whatever other topical. Yeah, it does have the potential that it could really move the needle in a major way, like you hear from some people. But that wouldn't be my first go-to. Is kind of my answer to just to top off what you said.
Yeah, I think that's right. And I think you made a great point. It really does seem to work for some people, and whether that's a real response or placebo, I'm not going to point fingers. I certainly don't want to pop anybody's bubble. If it's working for you, and there's minimal risk, and maybe the big risk there is the cost, I suppose. Yeah, of course, go ahead and use it. And there's no arguing with what your experience is. If you say, yeah, my knee feels better when I take it, I stop it, it hurts more. Well, yeah, okay. But I think you're right. If you're looking to kind of, plan a real strategy, it's hard to really kind of rely on that as a significant step towards improvement.
Hey, Dr. Johnson, any chance you're familiar with that horse ointment? I think it's one of those like DMSO ones. Do you have much familiarity with that?
Very little.
Okay,
someone
I
just
didn't know if
mentioned
you
to me the
did.
other day, and it's something I've been meaning to look into because it is an interesting one. I wish I could tell you more about it. I will have to make a point to find out because it did come up for the first time, kind of hit my radar just real recently, and I'm wondering if there's something there or not.
Yeah, I've done very little digging on it, but again, because it's kind of tough because when people talk about this horse ointment, and they never actually bring me the actual bottle so that I can look it up in more depth. But from my understanding of it is that it has a potential to be toxic to humans, as some kind of liver damage, and so that's why it's currently not allowed for humans. But again, I'd have to look into it more detail once a person, who's a veterinarian or whatever, actually brings me that bottle and I can look at it in more detail, the human applications. But that was kind of my general feel from the secondhand information. And then when I went to dive into it. Yep.
Interesting. Yeah, and that's a great point, because that's one of those things like we've just been talking about all these other options that may not be particularly useful, but at least don't carry a huge risk with them. Obviously, if there's a significant adverse effect, you have to kind of step back a little bit. Liver damage is certainly no joke. It's a tough one to come back from if it's significant. So, yeah, I'm with you. I think probably steering clear and maybe using those things that have at least been, assessed for human use would be a good place to start and go from there.
Actually, kind of on the same topic there, it was Dr. Forrester, our hand specialist, who told me, for a long time, like those like really bad cuts that people would get on their hands and they didn't want to go to the doctor, they would super glue it. And Dr. Forrester actually told me that you should not do that for the reason of if enough of that is absorbed into the bloodstream, that it can be just fatally liver toxic, which I'd never heard before. I always heard that, barefoot water skiers or whoever, that they could get by very simply with, a bad cut that they're kind of trying to stabilize with just super glue would work. But I guess maybe a bit risky there from what Dr. Forrester told me.
Yeah, who knew? I guess it's one of those things. I mean, obviously, there's sort of we use some medical grade. It's like super glue, not the commercial stuff that you get off
the stuff shelves. You put with the steri strips, whatever that is. Yep.
I'm wondering if that again kind of gets a little mistranslated. Well, if they're using it in the OR, maybe it's okay to use the stuff I get off the shelf at my local hardware store. Clearly different products, and so yes, absolutely. Anytime it's not marketed for human use, probably
best not to. Yeah, there's a reason for it.
Right, right.
Well, another question I get a lot from my patients, and I'm curious if you have any additional things that you say. But let's say that you have that husband-wife combo coming in, and wife wants the husband to come in for this symptom or that, and it's maybe more of a minor thing, and maybe it's some clicking in the neck, and you say nope, otherwise you're fine because you're only having the clicking. That's the arthritis. Is there a certain way that you kind of tell the missus, hey, in the future, these kinds of things, these kinds of symptoms, you could come in for? Like for example, I say if he's having to take a whole bunch of anti-inflammatory pills every single day and he doesn't have an established diagnosis, well, then, yeah, you should bring him in to get that kind of pain evaluated. Do you tend to approach that in a certain way for how people should decide when is it time to come to the orthopedic doctor?
Yeah, I think that's a great question because there are a lot of things that people just, by routine will kind of, like you said, grab a handful of medication out of the, hopefully appropriately dosed medication out of the medicine cabinet and, just kind of get about their day. And I totally understand. I'm the guy who it was, 4 days after my appendix burst that my wife's dragging me, on death's door to the ER. But,
see them too.
A lot of stuff you just kind of put off, but maybe that was a bit too extreme. I think in general, you make a great point in terms of medication use. And if something's not calming down with at least reasonable treatment, let's say some rest, some ice, your ibuprofen relieves, Tylenols of the world, after I would say about that 7 to 10 day window, I think it's time at least to have it looked at. And it may prove to be very little or anything, if anything. But on the other hand, if it's really not calming down significantly during that time frame with the basics, it's at least worth having it looked at, and it may just be a matter of some more time or a little bit more, basic care, but it may be something that needs a little bit more elevated attention, and I think that's a good one. I agree with you. I think painless clicks are things that you can sort of say, listen, if it's not hurting, it may make some noise, but like you say, it's arthritis, or if anyone who's ever had a bad ankle sprain, their ankle probably clicks from time to time. That's just going to happen. On the other hand, if it's more pain and more swelling and those things are persistent or be progressive. So not just, it's been a 2 out of 10 for a while. It was a 2 for a while. Now it's up to a 4 and it sort of feel like it's on its way to a 6. Well, those things are certainly more concerning and probably need to be looked at. And I think you would probably echo this, is some of those things, the sooner we're able to identify and address the problem, the better the outcomes are overall. Sometimes that horse gets out of the barn and we're chasing it back in. It's a lot harder to do than if we can kind of catch it on the way out and keep it from getting too far astray.
Yeah. So, and of course, you're the foot and ankle specialist. You see a lot of ankles, and so you would kind of say that same thing for that. Oh, is it a sprain that that'll get better by itself, or needs the doctor's attention? Outside of severe pain, or maybe the person is really limping, can't put much weight on it, for a few days. You kind of use that ballpark, that 7 to 10 days, as long as the pain is livable and as long as things are improving. Those ankle sprains, you can kind of let them go.
I think that's generally right. If it's improving in that time frame, it doesn't have to be 100% better, but demonstrably better. I look back what I was doing a week ago, and yes, today I am doing clearly better than I was then, even if I'm not where I was before I injured it. I think if you've got a lot of swelling in the ankle, it's difficult to put weight on it. Certainly if it's painful to move, and those things are a little bit subjective, but if they're not kind of getting better, they first sprain an ankle, it's going to be sore and swollen, but if it's not calming down and those things are kind of lingering, certainly inability to put weight on it, that's a big red flag for me. That definitely needs looking at, because that kind of now tips it. Maybe it's not a sprain, maybe it's more a fracture. One of the the bones around the ankle is broken.
Yeah.
Those things need to be looked at. It's not uncommon too for people to have a little bit of sort of hesitancy in using the ankle for a little bit. But if you're feeling sort of that chronic sense of distrust of your own ankle, like I want to put too much weight on it, it feels like it might give out or roll, or it feels unstable. Those things also, I think, need to be looked at, and those may indicate a more significant injury. And it, again, doesn't mean we're jumping right to the surgical fixes, but some things that we can do that would give it some more support and the right environment to heal properly and really reduce the risk long term of having to have that surgery done. There are things we go in, like I mentioned, and kind of reconstruct or tighten up those ligaments. And sometimes people, because they didn't treat that sprain correctly at the outset and it healed, but sort of poorly, they're left with these long-term symptoms, and those are the ones that we're sometimes going back in to have to do the surgical fix. Whereas if we had caught it earlier on and gave it the right environment to heal up properly, and maybe the ankle sort of falls in that 80-85% of cases where they do pretty well without any additional treatment, just apart from the basic conservative stuff.
Yeah, and I hear you. We've talked about this quite a bit before, that limping, especially I use that as a big determining factor, just watching someone walk and, how far out from the injury they are. I mean, if you're limping and just your ability to bear weight is not getting progressively better as these days go by very quickly, then that can be a big thing, because, like we've talked about, you're limping. Well, then you start favoring the other side, and then you're more likely to tweak the knee or favor the back and herniated disc in your back, and then have 2 or 3 problems. And I like that analogy that you gave before. It's like pulling the thread on the sweater, versus if you just clip it early and get ahead of it. Yeah.
Right. You're not left with a big mess of yarn. I think that's absolutely correct, and sometimes people, at least I've seen this too. I think people, I'm not sure if it's denial or just a difficult time seeing it in yourself, but like, your spouse mentioned that you're limping. Do you know that, or have you seen that? And they're not aware of it even. Mm-hmm. So if you've got someone, a close friend or family member who says, man, what are you limping about? Those may be indications that something's a little bit more significant than you're appreciating. And sometimes it's these progressive, arthritic conditions where you're starting to alter the way that you move, really on a subconscious level, one of those basic programs that our brain has. We don't have to think about, lift foot, swing forward, heel down, toes down. You just kind of walk. But the body's also very canny. It doesn't want to be in pain, and so it'll change the way that you do things very subtly without really asking permission. And all of a sudden you'll be limping consistently, but you don't even know that you've drifted into that. And someone may say, hey, what's going on? Maybe take that a little bit more seriously, because they're kind of able to see you as an objective, third person observer, and can point out some of those things to you. And so that's sometimes, as you say, where a spouse will say, hey, listen, he's been limping for years. He may not know that, but it's been getting worse. And certainly that can be the case too, where you just don't realize it because it happens so slowly and so gradually.
Mm-hmm. Yeah, absolutely. You kind of hit all the different ones that are on my list for, when you should go to the doctor. And I think I heard you say that the last one that I see on my list here, it's that if things are getting worse as the days go by, day 2, 3 of this, and you're getting more symptoms are more intense. This is not a good sign. And so definitely time to come to the doctor. And Dr. Johnson, in just a minute here, we're going to take a commercial break, but I wanted to remind people who are listening to us where they can find us. Dr. Johnson and myself, Dr. Wiersbecki, we're at Florida Orthopedic Specialists. And if you ever want to give us a call and come into the clinic and see us in either Port St. Lucie or Stuart, our number is 335-4770, 335-4770 at Florida Orthopedic Specialists. And Dr. Johnson, if you hang on, we're just going to take a minute or two break for commercials, and then we'll get back to it.
Sounds great.
All right. All right, and we're back on the forum, and I'm your guest host, Dr. Joe Wiersbecki with Florida Orthopedic Specialists. And again, our number at Florida Orthopedic Specialists is 335-4770 if you want to come and see us in our Port St. Lucie office or in our Stuart office. And my guest today is my partner, Dr. Paul Johnson, who is a foot and ankle lower extremity specialist with the same practice. We're back, Dr. Johnson. You there with us?
I am. Can you hear me okay?
All right. Yep. We got you.
Perfect.
All right. Great. Well, hey, a question I had for you before the break was talking about some of the surgery that you sometimes have to do on some of those, ankle sprains. Like we were mentioning, for the most part, if you if you get lucky and well, you don't get unlucky and need surgery right away on that wrong kind of ankle sprain. The majority of ankle sprains do well non-surgically, as long as, like you said, you treat them right. So what does that surgery sometimes involve for ankle sprains that are unlucky, let's say?
Sure. I think the most common one is going to be a sort of a reconstruction of what we call the lateral ligaments, the ones that are on the outside half of the ankle. The two big ones that are often injured during the traditional ankle sprain are out on that side. We tend to roll that foot inward, and by extension, we stretch and tear the ligaments on the outside part of the ankle. So if they don't heal at the right tension, you've got a little bit too much play in the ankle. In fact, you could have a lot of play in the ankle. And so sometimes that can be very clear instability. You worry about anything uneven in terms of the ground because your foot's very likely to roll underneath you again. Or it can be more subtle. It can be a little bit more of a just kind of general achiness and sort of swelling in the ankle. Everything else checks out as being okay. Sometimes it's that extra play in the ligament. So we'll oftentimes go in and actually we can tighten them back up and sort of get a little bit more tension in them. And more commonly, especially in people who are all athletically inclined, and it doesn't mean you have to be, playing in the NFL, but if you're a runner or a cyclist or you like, weekend sports and so forth, you really want to have a good solid ankle under you. And they've shown some very good results with some augmentation. There's a device that we now implant. Basically a woven piece of looks like a very thick thread, almost like not to dumb this down too much, but like a shoelace, that kind of thin but wide tissue.
Yeah, very similar to how we talk about ligaments. Yeah, kind of like that interwoven rope.
Right. It's it. And so it's made of this, fiber wire. It's technically a fabric, but it has a very high tensile strength. And we'll actually anchor that in the bones along the same lines of the ligaments. And that's a great way to kind of reinforce and back up the ligaments and give them some extra strength. They've shown some really impressive results with these things I'm not even sure I would do. But these big NFL players with these chronic ankle injuries, they get these fixed up, and generally it's an 8 to 12 week process of protecting the ankle and minimizing activity and getting some motion going, and then building up some strength. Well, these guys, and they're not little gentlemen, they're big folks, are out there doing, like agility training 3 weeks out from their surgery on the basis of having this additional implant. So it's a very powerful thing to see that, and are doing great. So for people who are, more, my stature, a little bit more human looking in terms of just, basic size and build and all that, you've got a great way to reinforce those ankle ligaments and get folks back to a much higher level of function, I think more safely and reliably, because believe me, the last thing you want to do is go through that whole surgery and then 6 months later you re-roll the ankle and you tear it all apart again. This is a nice way to kind of minimize the damage done for any future injuries and to get you back a bit faster after the surgery, so the downtime is significantly shortened up and we can get folks to a happier place much quicker.
And this kind of surgery that you're talking about, using this, mesh, this kind of modified, ligament, is this something? This isn't something that needs a big scar. This is probably something like an arthroscopy. Is that how you do this surgery?
It's a pretty minimal scar, really. So we're really looking at if you look at your ankle, there's that bump on the outside part. That's the lateral malleolus. That's sort of one end of where the ligament goes, and then the other end of the ligament is about 3 centimeters or so away from there. So the incision really just needs to be big enough for us to follow that course, and we can kind of sneak it in there. Very minimal incision. We're able to do that, of course, as an outpatient surgery. The whole thing, maybe half an hour. So it's a pretty quick surgery, but can make a huge difference in somebody who's been dealing with these issues, especially these chronic injuries to the ankle, that instability, the pain, the swelling. It's a great way to get folks back up and going again and make such a huge difference for such a relatively small procedure.
And you said your typical recovery time with some of the newer technologies and tissues that you're using. What's the typical recovery for someone with just that chronic ankle sprain kind of pain that's let's say no arthritis or anything else? What's your recovery like?
So what I tend to recommend is we protect things for about a 4-week period, really let the healing get a head start on us. And some of that's the soft tissue incision stuff, but also let that ligament start to heal in. But with that backup, with that sort of, we kind of call it a belt and suspenders. You've got redundancy in how you're keeping your pants up. Well, this is a redundancy in how that ankle is going to be stable. We're able to really start the motion much earlier, and I think by 8 weeks, most people are out of their protective boot, have been probably doing physical therapy for a good month or more, are back doing some basic activities. And I would say certainly by the 12-week range, people are starting to increase those activities to a fairly high level, and then from there advance to tolerance. So if you're looking to get back to sports, especially, those cutting activity type sports, soccer is obviously the classic one with a lot of rapid changes in direction, but any sport like that, it allows you to kind of pretty quickly, I'd say within about a 3-month window, get back to a pretty significant level of activity. It may not quite be 100% by that point, but we're looking 85, maybe 90% for the average person. 100% just takes longer. It's probably somewhere in the neighborhood of a 6 to 12 month window. But to be 85% by the first 3 months, it obviously sort of front loads that. So people are getting back doing those things, and then just kind of the changes happen more slowly, so they're not as readily noticeable.
And what did you say as far as the early stage? Let's say it's someone's right foot. How long until they're off of the boot and driving type things? What would you give for the ballparks? With those, what would you say?
So I would say for driving and so forth, it's probably about a 2 to 4 week window before I really feel comfortable having to do some of those things. And I think that's more an abundance of caution, especially as I say with these newer techniques. If you've got 250, 300-pound guys doing agility drills at 3 weeks, then certainly you can probably drive on the average person. On the other hand, I'd hate for that ankle to be the weak spot in the chain of events that has you slamming on the gas pedal or the brake rather to avoid an accident. And so I want to make sure the ankle is ready to respond to those types of moments. And so I'd say, listen, around the 2 week mark, I see you back. We're doing okay. We're getting stitches out. Things are looking good. And then kind of getting a feel for it over the next week or two. And by that 4 week mark, if people are feeling comfortable and doing well, being able to do some basic driving, I think at that time is probably realistic, as long as they feel comfortable and confident. That's the other side of it. It's not just enough for the time for the healing, but how comfortable are you being able to get that foot from the gas pedal to the brake in a hurry? And so it always comes down to that individual decision. But certainly at that point, it is very feasible.
Yeah, absolutely. And I know you do a lot of hip replacements, knee replacements. So what's that recovery like, for your standard hip or knee, as far as, when they're more confidently putting weight on it and driving? How do you ballpark there? And I know there's two completely different problems here and topics, but how do you ballpark their recovery times and what you normally see for, after a hip replacement or knee replacement that you do?
Yes, I think hips in general tend to do a bit better more quickly. And I say that in as much as in the early goings, people are up and walking on their hip replacements. That's day one usually. And you take away that huge source of pain, that arthritic pain. They've got a much more comfortable joint, and the surgical pain, which of course there's going to be some, calms down relatively quickly. So instead of that pain that's kind of getting worse day to day or week to week, it's actually getting better day to day. And next thing you know, they're up and moving. For those hip replacements, I've seen anywhere from as early as 2 weeks, people literally driving themselves back to their first post-op appointment, which may be a little bit on the
sometimes
early
getting
side
on the golf course. Despite our recommendations. Yep.
Exactly right. But I guess that's kind of a testimonial to how well these can do. What a powerful surgery. But yes, I agree with you. My job is to be risk averse as a surgeon. I don't want to take chances on behalf of my patients, so I want them to do well. So anything I can do to keep them out of trouble, I'm a little bit like a parent, I guess, with a child in that sense. True. And I don't mean to be, pedantic, but just in the sense that I want everything to go okay. I want them to do well. I don't want them to get hurt. So I'm going to err on the side of caution. I think realistically for hips, though, that 4 to 6 week window is probably about right. Mm-hmm. I think with knees, it takes a little longer. And there's a lot of question as to why knees just do take their time to get better sometimes. But I would say by 3 months, hips are doing generally pretty well on average. They certainly can take longer than that, don't get me wrong. But I think we're looking at kind of that bell curve. That's probably when most people are feeling pretty confident and really are ramping up activities. With knees, it's more like a 6-month window on average, and before people are back doing those same types of activities to the same level of comfort and confidence. And so I think with driving, it's also a little bit longer to get back to that, of course, with the right knee in particular. And I think that's probably more like the 6 to 8 week window, maybe a little bit longer in some cases, just because of that extra pain and swelling that seems to come with knee replacements. I want, again, people to be very comfortable being able to safely operate the vehicle. And again, maybe that's a little bit more of an abundance of caution than anything else, but much better that than the traffic accident that could occur if they're not ready.
Yeah, and you touched on it, and patients ask me all the time, about why the difference in post-op healing, versus the hips and the knees, because I hear it all the time. People do so well with the hip surgeries. They're up and walking the next day. They feel completely different than before going into the surgery, but the knee takes so much longer to heal. Is it because the knee is much more of a dynamic joint, the hip's more stable? Is it a function of mechanically the way they're built, or what's your theory about that?
That's absolutely my theory. I think it has to do with that. And so with the hip, the motion is more constrained. We kind of think of what we can do with our hip and swing it forward to the side, and we can rotate it a bit. But with the knee, you're bending this potentially 165 degrees, straightening it out all the way. It needs to be able to bend and function at sort of very disadvantageous from a physics standpoint, different angles while you're going through a standard motion. You can imagine what's going through your hip while you're, let's say, going up a flight of stairs in terms of having to kind of bend the knee. You load it, and then you fire all those muscles to bring your full weight out to a straight knee, and then you kind of, rinse and repeat. And so it's a lot of stress and a lot of sort of, like you say, very dynamic function of the knee. It also has a much less robust sort of muscle, soft tissue envelope is the sort of the medical term for it. But the hip is buried under all these layers of muscle. It's a fairly deep joint. And I think that's probably to its advantage when it comes to something like recovering from a surgery. Whereas the knee, on average, you can kind of feel every little nook and cranny around your knee just from the outside. And you can see all those things. And so there's less sort of soft tissue to absorb the swelling. It probably slows down the healing a little bit to have a little bit less robust soft tissue envelope again. And that may be playing a role. And I think the other part, and this again is a little bit speculative, but there are a tremendous number of nerve endings in the knee, and those are reporting all those basics that we were talking about with the dynamic function. What position is the knee, and what kind of stress is going through the knee, how much inflammation is there, and all that information is going back to the brain so it can coordinate the efforts of something as simple as walking. And when the knee has sort of been injured, as far as the knee is concerned, it's a trauma. When you're having a surgery, all of those nerve endings kind of light up, and you definitely feel it. And there's probably a component there as well with knee replacements. The big sort of early post-operative hurdle for a lot of folks is, after sort of the pain and swelling, of course, is getting the knee moving. The knee wants to lock up and tighten up and scar down and not move. It seems to be a natural, almost protective mechanism. Oh, the knee's hurt, then just lock it up so it can't move, and if it can't move, it won't hurt. It's not very functional, but it sort of, on a basic level, evolutionarily makes some degree of sense, before surgeries to maybe address these problems. And so I think that also is part of that sort of extra long duration of recovery, just sort of fighting off the body's natural tendency to want to lock that knee down and keep it from moving.
Yeah, yeah, and the procedure that you do for the knees and for the hips, it's the same procedure that Dr. Powers does with the muscle sparing approach, which has been a real game changer for the hip and knee replacements and the recovery when you're not having to cut muscle and heal muscle. In patients, of course, this gets all around now just how important this is, and I don't know why all orthopedic surgeons aren't doing the muscle sparing approach like you and Dr. Powers do. But then, everyone always wants to know what's next, because Dr. Powers and you have been doing this for 15, 20 years plus. Is there anything newer that's being applied that's really helping to kind of improve the procedure, improve the recovery, the safety? What's outside of muscle sparing? What's next?
Yeah, I agree. I think muscle sparing has been a very, very a huge step forward. The less sort of collateral damage you're doing during the surgery, the better. And I think a lot of the other efforts have been sort of directed towards that. So one of the things that we've been moving away from in years now is the use of actually a tourniquet. So traditionally, you put it literally is a tourniquet on the thigh, and you would sort of
kind of minimize
blood out of the leg
flow so
yeah.
that you can see the area more clear and
correct and reduce that blood loss during the surgery. And so that was the sort of the thinking. Okay, well, if we put the tourniquet on, we do the surgery, and we take the tourniquet down, restore the blood flow. That lets us do our job more readily and minimizes the blood loss during the surgery. But I think, as it turns out, you can actually do the surgery now with some of the newer advancements without the need for that tourniquet. So you can imagine, anybody who's ever even thought about it or even had a tight blood pressure cuff on, how uncomfortable that is. Well, that's up for an hour, maybe 90 minutes in some cases for these knee replacements, and the leg knows it. And so after the surgery, that can actually increase the levels of pain. So we've been able to move away from that thanks to some alternative technologies that help us control that blood loss during the surgery. So there are some medications now that help to kind of coagulate the blood more readily. without a huge increase in any sort of risk that can be associated with clotting, which has been very, very powerful. Many folks, not everybody, but most folks are very amenable to use that medication. There are certain medical conditions that make that a little bit more dangerous. There's also some procoagulant technology that we use. There are sort of electrocautery, but now also things like Aquamantis, which are a different way to cauterize tissues that are more effective and to reduce the intraoperative bleeding. And the technique that we employ now sort of goes step by step, and you're able to identify bleeding early, correct it as it occurs, and that way the blood loss isn't there. Whereas you can imagine if you put this tourniquet up, there's no bleeding. Well, that's great, but when you take
there's
the
no blood,
down, all
no
those
oxygen.
little injuries suddenly emerge, and you're like, oh my gosh, there they are. And so it allows you to be able to identify them more readily and more quickly and address them as they occur. And so I think with that in mind, we're able to kind of really mitigate the need for that tourniquet and its sort of negative effects without really placing the patient at any increased risk, and able to do the surgery just as efficiently. So one more way to get folks through that recovery process with less sort of post-operative pain and improved post-operative function.
Yeah, yeah, and I know another big thing that you guys are using a lot more of is the robotics. That's the Makoplasty, right? And how you use robotics in order to make things even more precise and accurate.
That's it. It's a really neat technology, and I think it kind of combines the best of the surgeon's experience with the enhanced ability to kind of implement our plan. So, normally we get these x-rays and we template out. We sort of say, okay, we think it's going to be this size implant. We're going to position it here. We're going to look for these things, and we're able to execute that pretty readily. But what the newer technology does is a 3D scan of the knee, and even before the person enters the operating room, you have that whole thing templated out. And then it's the robot that helps you make sure that plan is implemented precisely. So it's still a lot of surgeon input to make sure that plan is appropriate and best for the patient and for that knee or that hip, as it might be, in terms of the mechanical function after the surgery, but really lets us make sure that plan is put into place exactly within a fraction of a millimeter, which is pretty impressive. And so with that in mind, we're able to make sure that what we kind of template out is exactly what occurs, near as makes no difference in the operating room setting. And it's a nice way to be able to offer that blending of the technological precision with surgeon expertise and knowledge.
Yeah, and I know you've been the orthopedic world, and us has been utilizing these newer things like the lack of the tourniquet and the robotics the past few years. And in the lab, people tout all these things like the 15-year or the 30-year knee, in the laboratory. Are we seeing any kind of real world data yet? As far as how the technology, like the lack of the tourniquet and the robotics, how they're changing outcomes, either short or long term. Is there any data yet on that? Or patient experience that you can?
There's some early data now in terms of some of these things having benefits. So between, let's say, the muscle sparing, the tourniquet approach, there are some good data that show that postoperative pain is statistically reduced, so significantly reduced after the surgery, looking at folks who had tourniquet, who did not have tourniquet, people who did traditional versus the muscle sparing. And those benefits probably extend about 8 weeks or so, maybe as long as 12, but at least 8 weeks out from the surgical procedure, meaning that during that time frame, you've got a head start over your counterpart doing it the more traditional way. And that's great. Even if it does wash out by the end of 2 or 3 months, then, fair enough. But at least then during those first few months, you've had that advantage. So if there's a way that I can do the surgery that makes your pain less and your function better, well, yeah, of course I'm going to do that. That's my job. So I really think that those are great technologies for that. As to the Makoplasty, there are some good data that are starting to emerge that show some benefits, especially in more severe arthritic conditions, greater degrees of deformity or wear inside the joint. But the data pools are still relatively small because it is a newer technology. And so the thinking is, as we were able to get more and more data, that some of those other differences can emerge and show more significant benefits, even for the more run-of-the-mill arthritic knee, if there is such a thing. But I think at this point, it's still a little bit preliminary for those types of knees. But certainly, I think for the more advanced deformities, we can plot and plan. It really does show the benefit there.
Yeah, and I think it's an easy jump to and a natural, based on reasonable science, that if there's less pain, there's less narcotic use, we see less limping, that we're going to have all kinds of positive downstream effects from just some of those simple interventions that we don't even need studies yet to know that we're going to see some positive outcomes related to some of these newer techniques and procedures.
Oh, absolutely, and that's a great point. I mean, there's probably no bigger hot button issue. Well, prior to COVID, I guess, and I put my foot in my mouth here, but prior to that, certainly the narcotic issue was a huge one, and you can see across the country, and certainly here in Florida, there have been huge legislative changes in how those medications are prescribed and their volume and how often we can use them, and all of these other sort of restrictions to try to minimize that impact. And it's been well documented, as I'm sure everybody listening knows. Just how dangerous those medications can be. They have their appropriate uses, but certainly if we can minimize how many and how often and for how long those medications need to be used for, absolutely, what a huge positive difference it can make in the average, across the board. These are tremendously high numbers for these procedures now, so that it's some of the most common surgeries being done, the hip and knee replacements, and those numbers are going to go up. We've got a population that is aging, but also is staying very active. And so they want to be able to continue to play tennis. Well, yeah, great. So we can do that now. We can do the hip and the knee and get you back out there doing those active activities. But with such a high prevalence, any little difference that we can make in terms of some of these bad outcomes or some of these narcotic issues are going to have a huge sweeping change because of the volume.
Yeah. And another question for you that you get all the time, I get all the time, about the lifespan, with a hip replacement and knee replacement. And I know it's going to be very patient specific. People who are more overweight, more underweight, have more risk factors, less risk factors. What's your ballpark for how long is that hip going to last you? How long is that knee going to last you? What's your answer?
Yeah, so I tell folks on average that we're looking probably in the range of probably anywhere from 15 to 25 years. And I
for
think
both of them, you say 15 to 25.
Yeah, okay. And I think it's probably going to be on that higher end of that range as we get more and more of the data. There was a huge changeover sort of in the early 90s. They kind of changed the way that some of these things were being made and processed, parts of the implants, in particular the plastic or polymer piece that goes in between the metal. And with that change alone, the lifespan basically increased by about 5 to 10 years. Wow. It just wears much more slowly. It's not as fragile.
And that was how long ago? About 20 years ago? Did that change?
Yeah, it was probably a little more. I would say about 25 at this point. 25. And so we're seeing a lot of these long-term data are starting to come out now. There was actually a couple of recent studies that looked at the reason these implants ultimately failed and needed to have a revision done over about a 10-year span, and they sort of stacked these sort of pre and post this change in the way that this implant is manufactured. And before that, the number one cause of failure was this polymer wear. It would wear out, and that had to go back in and replace it. Plus, when it wears out, these little particles would be emitted into the joint, and that would maybe accelerate the loosening of the metal from the bone. And so there were kind of a cascade of effects there. After that has dropped out of the top 3 reasons for implant failure. So it was a huge difference, and that's looking at about 10 years of implants. And so as we get more and more of those data, I expect to see those numbers actually get further and further apart in terms of the reasons for failure. And so, of course, it doesn't mean that we've ironed out all the kinks, that there's nothing that could possibly go wrong, but we eliminate things, kind of chip away at it, make it more and more perfect. And even now, the risks of these procedures are so low. If we can make them even lower, fantastic. But it's nice to see one of the big ones kind of taken off the list as a potential reason for needing to go back in and do another surgery.
Well, great. And Dr. Johnson, it's perfect timing because we're about done for today. But I know that if people want to call in or hear you more, that you do the near weekly radio show on WPSL 1590. And yeah, thanks again for everyone. And of course, if you want to see Dr. Johnson or myself in clinic, the telephone number is 335-4770. I'm Dr. Joe Wiersbecki and Dr. Paul Johnson. We're at the same practice, and we have the office in Port St. Lucie and in Stewart. Well, thanks again, Dr. Johnson, and for everyone for listening, and I'll be here next time.